Department of Medicine as well as Khyber Teaching Hospital invite you all to this Stroke Symposium. I am thankful to you all for attending it. We have our Honorable Dean, Professor Organising, on the stage. Besides, we have Professor Dr. Muhammad Hamid and Professor Dr. Intikhabat, both of whom do not need any introduction. We are very thankful to you, sir, for honoring the occasion. May I please invite Dr. to come on the stage and recite a few verses from the Holy Quran.
بسم الله الرحمن الرحيم من أجل ذلك كتبنا على بني إسرائيل أنه من قتل نفسا Because of that, we argue for the children's society that if anyone killed a person not in retaliation of murder or to spread mischief in the land, it would be as if he killed all mankind. And if anyone saved a life, it would be as if he saved the life of all mankind. And indeed, he had come to them of his sins with clear proofs, evidences, and signs. And even then, after that, many of them continued to exceed the limits in the land.
As you would all be aware that renowned hematologist Dr. Tahir Shamsi recently passed away, so we would like to use this forum to pay acknowledgement and tribute to him for all his services. We will now officially start our symposium. Before we move on to the presentations and the lectures, I would like to tell you that we are arranging the symposium in collaboration with the Pakistan Society of Physicians as well as the TMC Alumni of North America. Apart from them, we have many other organizers from all the different hospitals of Khyber Pakhtunkhwa. Now, I would want to invite the first speaker. He does not need any introduction. You all know him. He's working as an associate professor in the Department of Medicine. And that is Dr. Iqbal Haider. Dr. Iqbal Haider has got many research articles in his name and have been published in both the national and the international journals. Apart from that, he also has good enough of knowledge in the field of medical education. So I welcome Dr. Iqbal Haider to please come and talk about the burden of stroke, the need of stroke units in Khyber Pakhtunkhwa.
Bismillahirrahmanirrahim. Good morning. Thank you so much, my mentors, Professor Intikhab Alam and Professor Humayun Saab. It's always a pleasure to be with you every time, and thank you so much, Mahmood Saab, to be a chief guest of this event. I'm just an appetizer for this symposium, and I have a limited time, so I will briefly discuss why we are going to discuss this topic and what is the actual burden of stroke, and do we really need stroke units in Khyber Pakhtunkhwa. I'm Dr. Iqbal Haider, working as Professor, Department of Medicine, Khyber Teaching Hospital and Khyber Medical College, Peshawar. We have to basically explore four basic questions. What is really the burden of stroke in our society? And what makes it so much heavy burden? Are there some special risk factors which we must address? And is there actually the role of internist in the management of stroke? And are stroke units really needed? As far as disclaimer is concerned, I will quote Faiz Ahmad Faiz साहब, हम खस्ता तनों से मोहतसिब हो, क्या माल मनाल का पूछते हो, जो उम्र से हमने भर पाया सब सामने लाए देते हैं. So pictures and few slides have been taken from the Google. Learning objectives are brief, and we will focus on these points. Stroke. Unfortunately, stroke is the second leading cause of global mortality as far as 2016 data is concerned, and it constitutes almost 10.2% of all the global mortality. Out of all neurological deaths, 67.3% of total neurologic deaths are contributed to stroke only. And it contributes to 5.2% of disability adjusted life years just in 2016. Roughly, it constitutes 15 million cases of stroke every year. And the prevalence of stroke is particularly increasing in the low-income and developing countries. And South Asia is carrying the major burden of stroke globally. Why South Asians? Because South Asians, I think so, are different from the rest of the world in terms of high prevalence rate, younger age onset, high mortality, high burden of stroke, modifiable risk factors, and for unknown reasons, some non-conventional, under-researched risk factors are also involved in stroke pathogenesis. Pakistan, as per 220, is the fifth most populous country of the world with 225 million population, and we are having median age of 22.5 years. Unfortunately, being a Pakistani, we have limited, robust, population-based data regarding prevalence and risk factors of stroke. However, Khyber Pakhtunkhwa Integrated Health Population Survey, which was conducted in 2016 and 17, is elaborating 1.2% stroke prevalence in our province, which is roughly 1,200 new cases of stroke per 100,000 population. So, Pakistan is having 1.2% prevalence, which is higher in the nearby regions. 1% is India and Bangladesh, 1.15% in China, and 1.04% in the Sri Lanka. So we are leading as far as the stroke prevalence is concerned in the nearby region. The incidence of stroke is increasing in Pakistan, and unfortunately our young age population, which means less than 45 years of age, the prevalence is 25%, while in the West it is just 12%. Average age of stroke onset of ours is 52 years, while the Western world it is 67 to 70 years. And there is negligible awareness level of community and even healthcare professionals as far as stroke is concerned. So these all are alarming factors as far as the stroke is concerned. So is there some really under-research or some emerging risk factors of stroke are concerned? We all know as healthcare professionals, some are the established risk factors. We all know diabetes, hypertension, hyperlipidemia, tobacco smoke, obesity, sedentary lifestyle, cardiac arrhythmias. These are all established, but some under-researched factors are also involved. Our people are using hookah and more than 50 brands of smoking, either as a mice tobacco, which we call it naswar, chilam, gudka, chaya. All these are actually 100% tobaccos, and we people are totally neglecting this risk factor as far as our society is concerned. We are leading a source of consumption of ghee as far as this vanaspati ghee and cooking oils are concerned. Our per person consumption of ghee and white sugar is the highest in the world. Anemia. Majority of our female, unfortunately, they are still anemic, and it is one of the risk factors and it needs workup. We all know hepatitis B and hepatitis C virus, so much high prevalence in our society, and it can contribute to stroke. Rheumatic heart disease, thanks God, the cases are minimizing, but still it's a contributing factor. And COVID has given us some other thoughts to think about the evolving risk factors. Air pollution, अगर आप सोच ले तो जब कोविड का लॉकडाउन था तो सारी डिजीजेस के प्रेवलेंस बड़े जीरो पे आ गए. हमारे वार्ड्स खाली पड़े हुए थे, ना स्ट्रोक का मरीज आ रहा था, ना एमआई के मरीज आ रहे थे, सिर्फ कोविड की बातें हो रही थी. Perhaps air quality index of those days was very good. Road air pollution, all these can contribute and it needs workup. Climate change, न्यू इंग्लैंड जर्नल में बहुत सी स्टडीज पब्लिश हो रही है जो कि प्रेडिक्ट कर रही है कि स्ट्रोक कैन बी लिंक्ड टू क्लाइमेट चेंज. So, how many strokes units in Pakistan? The number till to date is only 10 stroke units in Pakistan, and only 6 centers are providing thrombolysis as far as alteplase is concerned. Unfortunately, no one in KP, our own province. So why the reason of limited stroke units in KP or even in Pakistan? Of course, financial and budget restraints of the public sector is the main factor, but there is poor infrastructure as far as referral of patient to the stroke unit is concerned. There is limited time bar, and implementation of strict stroke coding system is another frame factor. Availability of alteplase, DREB approved alteplase in 2020. So, and availability of alteplase is still issue. It's having very short half-life, and it's only available in public sector pharmacy. Trained stroke professionals As per Pakistan Stroke Society, we have 1 per 1 million neurologists in our country. So, is it feasible that only neurologists can manage or take this burden? Certainly not. Internists and healthcare providers of other specialties have to manage along with the neurologist, and they have to work in collaboration and integration. So dedicated stroke units and training facilities is mandatory. Till now, only 1 to 2 sectors are providing stroke fellowship, either in thrombectomy or neurointerventions. And the topmost on which we are working at this moment is awareness and education of the community and the healthcare professionals. Time is precious. This was the logo of World Stroke Day of 2021, because with each minute of stroke or cerebrovascular ischemia, 2 million neurons are going to die, and the risk of permanent brain damage enhances. So you have to act, be fast. Now, there is always a debate regarding the stroke units in the West, and the first published data of stroke unit is documented in the literature in the 1950. Of course, there was so much hue and cry, so much budget involved, and they were confused till 1985 that is really stroke units needed, or is it going to change the impact on the patient management as far as rehabilitation is concerned. But till 1995 onward, it's a consensus after evidence-based medicine and meta-analysis that stroke unit can change the management and the disability of stroke patients. And last year, with the Cochrane database analysis, which was basically from 12 databases comprising 29 randomized clinical trials, in which there was straight face-to-face comparison between general medical ward and stroke units, and some arms were regarding the different strains of the stroke units. They clearly documented that stroke units can decrease mortality, dependency, they can enhance discharge, early discharge home, they can minimize complications, and they can minimize the length of stay. As far as all these variables are concerned, they are remarkably improved in dedicated stroke units. So, the real benefits of stroke units, irrespective of age, gender, type of stroke, are decreased mortality, length of stay, discharge home, decreased complications, decrease of stay, and enhanced independence. As far as the financial constraints are concerned, this 10-year randomized controlled follow-up study clearly showed that direct and indirect cumulative benefits in the US and Canada alone, they can save almost 30 billion US dollars as far as these stroke patients rehabilitation and management were concerned. So I think so the message is clear that we really need stroke units for our province. Just brief, a stroke unit is basically a whole dedicated network in which you can either develop a geographically defined unit or a mobile stroke unit, which is called dedicated stroke unit, or even you can develop a mixed assessment rehabilitation unit, acute stroke admission unit in which less than 7 days onset of stroke patients are admitted, or more than 7 days of onset you can admit in delayed admission units. And of course general medical care unit is also a part of the stroke unit, but it's only for the management. It doesn't involve the rehabilitation perspective of these patients. At the end, I will rephrase the quote from Abraham Lincoln. It's not the years in your life that count, it's the life in your years. So we as a healthcare professional have to improve the quality of life of our patients, and it should be our main aim. I would like to acknowledge my team who worked with me to prepare this presentation. Thank you, my team. If you have any questions, you can approach me and listen. God bless you.
Thank you very much, Dr. Iqbal Haider, for this brainstorming presentation. I would just like to give you a reminder that those audience who have not registered themselves at the registration desk are requested to please do your registration so that you can get the certificates at the end of the symposium. If you have any questions to ask, you can please note them down, and we will have question and answer session at the end. I would now want to invite our Honorable Dean, Professor Dr. to come here on the stage and speak. Since he has a busy schedule awaiting him, he might not be able to stay with us, so he'll join us.
Bismillahirrahmanirrahim. Assalamu alaikum to all of you, and nice chilly good morning. I'm so delighted to see my senior, respectable Professor Humayun Sahab, and this really is the spirit to go ahead, that you never retire from an institute, and the fact that your colleagues have honored your presence, I'm mighty pleased to see you. So welcome to KMC. And Alam Sahab, again, a friend, association goes back to the days when we were in medical school. He was a star student, I was not, and but we would enjoy tennis matches in the doctor's hostel, and we started our practice roughly the same time around also. Beside my mind, I didn't really prepare what I was going to say to you all, but I would like to start off by acknowledging and thanking Dr. Zina Basha for arranging this under the able leadership of the Chairman Medicine Department, OS Naeem. I also want to acknowledge the presence of the Senior Faculty of Medicine, Professor Hashim Jamal Wazir Sahab. Nice to see you this morning. And I think Dr. Fawzan is there also, and my dear friend Professor Isaac, who for some reason is upset with me, but he will not tell me why. Now, just one. First of all, the introduction gave you an idea of the staggering figures that were presented to us, that this indeed is not just a serious healthcare problem, but a financial burden as well. Another message that was passed on this morning, and this is for the younger audience here, is that for the 15-minute presentation, Dr. Iqbal Haider had to do a fair amount of research in which he put heads together to get all the statistics and the data presented to you all. So, when you asked to make a 15-minute presentation, the amount of time spent presenting that is more than 15 hours. Besides, it's also important for you people to understand what communication skills are. Because by the end of the session, you know that so-and-so was explicit, so-and-so's expressions were good and all that. And these things don't come naturally. Some of the best orators in the world used to actually have themselves filmed, or they would rehearse in front of a full life-size mirror. So everything in life has to be deliberate. Now, coming to the field of stroke medicine, just a small background. Khyber Teaching Hospital really back seat as far as the three major hospitals are concerned. And I don't blame the government, I entirely blame the leadership of these institutes. The reason for that was I myself heard that no, this is an undergraduate hospital. We are just going to stick to undergraduate studies. What does that mean? Undergraduate studies. So let's take the example of medicine. Now Hashim Saab is sitting there and he's junior to me, but the time that he was studying in the UK, perhaps 20 or 25 years back, did you work as a medical physician? No, there was no concept of that. Even at the time when I was training in surgery, about 25, 30 years back in the United Kingdom, or Hashim was there, not to talk of the time when Naeem and people like Dr. Hamza were training there, we never worked with generalists. What my training pattern was that I worked with a general surgeon who had an interest in upper GI surgery. 6 months later, I moved to a surgeon with lower GI surgery. Then I did 6 months in vascular surgery, 6 months in breast. So they had already super specialized, excuse me, even at the district general hospital. And what happened here is that medical A unit, surgical A unit, then B, C, D, it went up to E, and almost went up to Z had the trend not been stopped. Because we now know that the future lies in specialized medicine and not in general medicine or general surgery anymore. But the reason for discouraging it is because there's a certain aura about being a generalist. You roll things from top to bottom, like a say general surgeon from the thyroid down to various veins, everything that in the middle. As a result, never really improved the services. Now, I do not want to bore you. 1 year that I have been here, we have advertised posts for oncology, rheumatology, neurology. The list just goes on and on. And stroke medicine, I will give the example of Dr. Fawzan, who's from SWAT and very closely associated with me. He walked from pillar to post, trying to get a job in his specialty, but none was available. So disheartened, he left Peshawar and he sort of settled down in SWAT. That's not going to be the future anymore. Then what happened, my experience at the PGMI, when I took over from Khan, was that the young doctors who had passed their one FCBS would come up and say that, okay, what do you want? I want to do general medicine in Lahore. I want to do general surgery in Wakand. I want to do gynecology in Rawalpindi. I said, no, Charles, you can't do any of this anymore. You want to do these general specialties, you will have to work in your own province. And if you want to go outside of the province, you can go anywhere you want to. The PGMI will pay for it, provided you go for specialties which are underrepresented and uninhabited. So we were able to change things around quite drastically there. And for instance, there are no anesthesiologists. We are having a tough time getting people in intensive care medicine. We got one blackmailer in emergency medicine. So we decided to, give them the market rates rather than the government salary. So you need to plan your future from now on, particularly the young doctors. And in this respect, I will again ask Dr. Iqbal Haider, who's ever so helpful to me in every aspect, that if we can have some counseling sessions for these young doctors as to what is available, what is the future, and where does the demand lie. Now, as far as stroke goes, we consider the condition that, we and these are nannies that are going to suffer this. But that's not the truth at all. My brother, who's my senior by when he was in his late 40s, had a massive intracerebral hemorrhage. And it was a very awkward situation for me me because they all looked at me for help. And there was nothing I could offer here in Peshawar. Nothing at all other than CDs. So we had to go to Peshawar. At least they had facilities for cerebral angiogram. And then the opinions that we got were so conflicting. One neurosurgeon, a rather trigger-happy gentleman working at MIMS, he needs now. And another one said, let's wait. So it was a very bad time that we went to. Ultimately disheartened, God was kind, we could afford. So we went to the Square, the National Institute of Neurological Diseases in London, and ultimately they did a cerebral angiogram. And the cerebral angiogram was done in such a way that actually the doctor calculated the internal carotid, the vertebrae, and ultimately an AVM showed up, which was then embolized. He's now fit and everything like that. And then the recent incident involving Professor Khalid again startled us that, you know, in the presence of plenty there is starvation. So why can't we have a stroke specialist? So immediately I advertised the position of a stroke specialist at KTH. Let's take the start. Let's take the initial start and then we'll see where it goes. So I think without further wasting your time, I have passed on the message. I will be supportive in everything. And sorry, I have kept quoting general medicine. It's the same for general surgery. We are trying to move towards the specialties now, and we lagged behind from the other two hospitals because our leadership here did not want it. They did not want pediatric surgeons. They did not want surgeons. Everything was general. And far, I'm trying with your help to move towards specialties. So I hope that you enjoy the rest of this session, particularly the students. I think there should be more of these rather than formal class, because get an idea of how your faculty is trying to prepare and give you the latest depending on what the evidence-based practices are and what the statistics and data are. Thank you so much for your kindness.
Thank you very much, Honorable Dean Professor Dr. Mahmood Aurangzeb. This is the second speaker for the occasion, Ashfaq Shoaib, who will be talking on the management of high-risk transient ischemic attacks and acute stroke. University of Saskatoon in 1989 and rose rapidly through the academic ranks to be appointed full professor in July 1995. He joined the University of Alberta as professor of medicine and director of the Division of Neurology in September 1997. He moved to Doha in January 2015 as the director of the Qatar Neuroscience Institute. His major interest is in the understanding of the basic mechanisms of cerebral ischemia and clinical trials in cerebrovascular diseases. He has published over 345 articles in peer-reviewed journals and has more than 700 abstracts at national and international conferences. His translational research mechanisms and the treatment of acute stroke. He also chaired the steering committee of large multi-center trials and is currently in the steering committees of 5 large multi-center acute stroke trials. So you can see how well versed he is with this subject. I'll now share.
Assalamu alaikum. Let me first begin by saying thank you to Thamur and the host committee for allowing me to make my presentation on a very important subject. The title is Transient Ischemic Attacks, Identifying and Management of Patients at High Risk for Stroke. I have no disclosures that would affect my presentation today. I have the following 3 main objectives for my presentation. My first objective is to talk about the importance of focal symptoms and also make you aware that all transient focal symptoms are not stroke. Secondly, that even if they are related to a possible stroke, all of these are not high risk. I'll outline to you where the risk is high and how to manage that. And that is, in essence, we do by investigating the patient. And so I'll talk about what are the important investigations that have to be done as soon as possible and how they affect your management, which is the third part of my presentation. I will stick towards evidence-based. I'll also make points where not to be too aggressive, especially in patients who may not have a high risk or whose symptoms may not be ischemic in nature. So those are my 3 objectives. And I'll go to my first slide. So this is how I'm going to break it down. So first is high-risk patients, and then a whole list of these other conditions that you've got to be aware of. So high-risk patients is my first group. Why do we call them high risk? We call them high risk because, remember, the definition of the group we are interested in are patients who have recovered from their symptoms, and their symptoms are minimal. So what you want to avoid is a big stroke. And we call them high risk because their risk of a big stroke is imminent. It's going to happen in the next few days. So one of our original publications from a long time ago, almost 17 years ago, shows you in here that the highest risk is in the first few days, in fact, in the first week. So if you see the patient 7 or 8 days or a couple of weeks later, the risk kind of flattens out. So everything is going to happen in the first 24 to 48 hours. And so when somebody comes in and their symptoms occurred on the day when they're being seen, that is a high-risk patient. To define where that risk is, we use a score. It's called the ABCD score. It was designed by a friend of mine who's in Oxford, Peter Rothwell, and he looked at several Oxford registries. And what we basically showed was that if your ABCD score is 4 or more, then you're at a higher risk. And the way they scored it was they looked at the age, the presence of hypertension, the clinical features, and the duration of symptoms. So if the score is less than 4, they are low risk. The risk of stroke is very low in the next 2 to 3 weeks. But as the score increases, you can see the percentage of patients with stroke in the imminent future increases. So what is the score and how do we do it? It's a 7-point score. Age more than 60, you score it as 1. Hypertension, whether present or history, 1 point. Clinical features are very important. If there's weakness, that has the highest category. See, that's 2 points. If they have true aphasia, not slurred speech, true aphasia, that's 1 point. So you can get a maximum of 3 points on the clinical features And duration is very important too. If it's more than 60 minutes, there's 2 points. Less than 60 minutes, it's 1 point. And if it's very brief, we don't score it. And diabetes is 1. So 7-point score, 4 or more is high risk. Now, of course, you'd also say, well, that's not the full story, right? It also depends on the severity of disease, the presence of either carotid stenosis or the presence of heart disease, right? So if you look at this holistically, there's a very good publication came out from colleagues of ours in the New England Medical Journal a few years ago. So I already explained to you, if they present early, less than 24 hours, they're at a higher risk of recurrent stroke. If the ABCD score is high, you can see this is a low score, 0 to 3, and high score, 6 and 7. You can see the big difference from 2% to 8% simply by looking at the score. Also, the underlying disease. So if they've got atherosclerosis in their neck vessels, or if they've got cardioembolic source, these are at a much higher risk than patients where you can't find a source. So keep this in mind as we go into my second objective. We believe that if you do acute MRI studies, and if you see no infarct, these patients are at a low risk of recurrent stroke. On the other hand, if you see multiple infarcts, these are the highest risk. So you can see the risk increases from 2% to 10%, and most of them happening in the first few days to weeks, right? This is really important. So that's your high risk group. Secondly, you've got these other symptoms. So TIA with an ABCD score of less than 4. I've already discussed this with you. I think the importance lies in how do you manage these patients. So it's not just a theoretical high risk versus low risk, but as I'll tell you later on, that high risk patients would require dual antiplatelets. The low risk, you may not give them dual, and in fact, you may not give them any antiplatelets. I saw a patient yesterday with isolated vertigo that was clearly from his inner ear disease who had been started on dual antiplatelets, which I think was a mistake, right? So low ABCD score, we call them non-consensus TIAs. In other words, some of you as experts would say, well, these symptoms are probably migrainous in nature. Others would say, no, I think this is stroke, a risk factor, right? So we call them non-consensus. The most common one you'll see in your practice would be isolated vertigo or visual symptoms, which probably indicate migraine. So these symptoms are positive symptoms, like zigzag lines or tingling sensations. These are unlikely to be ischemic in nature. Let me just talk about two other conditions. One is called recrudescence, and the other is cerebral amyloid-related transient symptoms. These are important because these are the differential diagnoses where you've got to be a little careful. You see them all the time in our practice. So recrudescence, here's a reference, is when, and you all see this, when somebody has a stroke and weeks to months later, they've made a full recovery, compensated, right? Then something happens. They have a bladder infection, or they've got pneumonia, or they haven't slept well, or somebody puts them on a sedative, or they've got electrolyte imbalance. And then gradually, so it's not quite abrupt, and usually they are mild, these symptoms come up. They're usually in the distribution of where the previous stroke was. So our tendency, of course, is, well, the person likely had a second stroke, and the risk is that you may give them TPA. So our policy is that in case the symptoms reemerge where they had previous symptoms, which could be months to years earlier, we do an MRI. If the MRI does not show a new lesion, which is usually diffusion-restricted abnormalities, we consider that this probably is recrudescence or reemergence of the symptoms from the previous stroke, and we treat the underlying metabolic, infectious, etc. etiology, right? So keep in mind, it's not uncommon. We see it almost on a weekly basis. The second one that's also very important is this condition called cerebral amyloid angiopathy related transient neurological episodes. This is important to keep in mind because these patients are potentially at a higher risk of a bleed. These are recurrent symptoms, and you'll see a patient complaining, oh, I get them every day, and they're identical. They're probably focal seizures, and these symptoms typically, like migraines, spread from one part of the body to another, or the contiguous cortex, and they're very recurrent and stereotype and occur multiple times. Usually the patients have underlying cognitive dysfunction. These are important to remember because if you put them on dual antiplatelets, they're at somewhat higher risk of a hemorrhage. Right, so this is my first part of the presentation. Secondly, how do you investigate these patients? And why do you investigate these patients, right? So talk about the tempo of investigations and keeping in mind, why are we doing this? Why would we do an MR? Why would we look for an arrhythmia? So when we talk about TIA symptoms, we put them into two big categories. They can be two big categories. Either lacuna, which are usually pure motor. Assalamu alaikum. Let me first begin by saying thank you to Taimur. Feel bad about it. It is important. You're preventing a stroke. Because some of my colleagues say, well, this is an elderly patient. How can I put them through all these investigations? You're doing this. In the New England Medical Journal about 7-8 years ago, that your percentage of AF increases from 3% to 16% with prolonged monitoring. Finally, I'll give you an example of a patient where multiple etiologies may be present. So recently we saw this patient on telestroke. Taimur would like this because he does this all the time. So this patient's CT scan is essentially unremarkable. This patient had transient left leg weakness, and his Doppler showed 90% stenosis of his left internal carotid and 85% of his right carotid. So this was likely the culprit. However, when we did the MR on this patient, you see these infarcts in multiple vascular territories. So this patient also had atrial fibrillation. Treatment, you first do the endarterectomy as soon as possible on the symptomatic side, which is the right side, and then put the person in long-term anticoagulation. So let me go into the long-term management of these patients after this slide. So this is what I want to do now. In the next remaining 6-7 minutes, I will talk about treatment to prevent recurrences. I am from Pakistan. I did my medical school and my house job in Pakistan. And I still, on a weekly basis, see a whole list of patients where somebody sends me prescription. And I'm just amazed that over the last 40 years, one thing that's not changed is this tendency of us filling in the whole page. Unless the patient needs a vitamin, don't prescribe them. Just stick to the basic principles. In the elderly, they're already in so many medications. So you've got to be very, very careful in not over-prescribing medications. That there is plenty of data that we do a lot of harm by prescribing too many medications. So let me just focus on my presentation, which is you're very aggressive with the modifiable risk factors. You've already seen whether they have atrial fibrillation, in which case you'll either give them warfarin or the new oral anticoagulants. If they have carotid stenosis that is symptomatic, you would go for endarterectomy. If it's asymptomatic, which is the patient I give you an example, we usually manage the risk factors. So the risk factors of importance are diabetes, hypertension, hyperlipidemia, and and smoking. We encourage activity. We encourage a diet which is mostly with the vegetables and nuts, etc., but less of saturated fat content. And for us, the highest risk in here, which carries about 50% of risk, are these modifiable risk factors. So I'm going to make 3 recommendations for you. My first recommendation is that you treat hypertension and you aim for the blood pressure to go down to below 140 systolic and 90 diastolic. Lower is better, and you need combination treatment. We prefer ACE inhibitors with diuretics as our first line therapy, and we may add a calcium channel blocker as a second line. So this is really important. The best bang you'll get for your dollar or for your management would be with aggressive management of hypertension. We are also very aggressive with management of high cholesterol. I need to update this. These are 2021 guidelines, which actually look at LDL targets in high-risk patients with less than 3 millimoles. Oh, I hope you have millimoles in Pakistan, because in the US, they somehow still go with milligrams. We'll have to talk about that later. And for LDL targets in the highest risk patients, the highest risk patients would be those with established atherosclerosis. So all our patients with ischemic stroke and with diabetes, you aim to go below 2 millimoles. And in most patients, we'll be using either atorvastatin 80 milligrams or rosuvastatin 40 milligrams. We have data that the lower the LDL, the higher the dose of the statin, the better it works. So remember, you want this patient now on an ACE inhibitor combination with a diuretic, and now you put them on a high dose lipid lowering agent. In that package, the third thing is the use of antiplatelets and anticoagulants. So anticoagulation, whether it's the new oral anticoagulants or warfarin, is for established atrial fibrillation. That's about the only place that you'll use them. The commonly used drugs are aspirin and clopidogrel. Ticagrelor is expensive, but it's not any better than clopidogrel. And we don't have much experience with Celestazol, but you may have in Pakistan. Also, there's a combination. So in patients with multi-bed disease, so they've got coronary artery disease and peripheral arterial disease, for example, or coronary artery disease and carotid disease, you may consider aspirin together with low-dose rivaroxaban or Xarelto on a dose of 2.5 milligrams twice a day. So how do we manage these patients? What are the outcomes? I wanted to share with you a publication that came out 2 weeks ago in the journal Stroke on the physician patterns. And the patterns are of patients coming in, so a very large series just came out online, and over 260,000 patients with acute stroke, so they are survivors who were discharged from hospitals in the US. And they were looking at a simple question. If somebody is already taking an aspirin, what are they discharged on? So interestingly, so among them, 44% of patients were on aspirin. And almost half of these patients, so 50%, still remains, 44% still remained on aspirin monotherapy. So this is the biggest group of patients who are discharged. And the point I'm trying to make is that if you are on aspirin and you have a stroke, by changing aspirin to a more expensive drug doesn't mean much. There's no data that actually you've changed the medication and the patient would do better. No data for that. And the practice supports that. Smaller group of patients in whom atrial fibrillation is documented, these are the patients who go on anticoagulation. Look at the very small number of patients who are actually on clopidogrel. And then if they have milder strokes, they go on dual antiplatelets to a quarter of these patients, where importantly, one of the two antiplatelets is stopped in 21 days. And I would bet anything with you that the pharma is always going to say, well, stop the aspirin. But it's only 25 minutes, but I tell you, trust me, stop the Planix. It's more expensive and it's not any better than aspirin. So dual antiplatelets, here's the indication for it. The clear indication for dual antiplatelet therapy, which is usually 21 days, is high-risk TIA, and I've talked about that with you earlier. So high-risk TIA patients need 21 days with an ABCD score of more than 4, or they have a minor stroke. And the reason why we do that is that in the very early days, here's the first week, your risk of events is high, and then it kind of goes down. By the second, third weeks, this is data from the POINT study, and if you're on dual antiplatelets, which is a straight line, it's much better than patients who are on a single agent, whereas the risk of hemorrhage remains somewhat flat with dual antiplatelets. So if they come in within the first week of the symptoms, you can give them 21 days of dual antiplatelets. Otherwise, it's a single agent. Also, very importantly, you manage their risk factors. So here's data, again, from the POINT trial, that if their blood pressure is well controlled, then the dual antiplatelets treatment works much better than aspirin alone. On the other hand, if the blood pressure is not well controlled, you can see the effect of dual antiplatelet is not as good as it would have been if you had managed their hypertension also. All other patients are candidates for single antiplatelet treatment. So symptoms secondary to low risk TIAs, non-consensus TIAs, etc., they go on a single antiplatelet agent. Conditions where dual antiplatelets have not been evaluated, so for example, large strokes, right? They go on single agent. I have just a couple of more minutes and then I'll wrap it up. I've already talked briefly about this. There's really no indication for switching patients if they've got recurrent symptoms. However, if a person bleeds on an aspirin, that person may be a candidate for switching to clopidogrel. I've also talked about this question that if they've got multiple vessel disease, and you can go from aspirin to a combination of aspirin and rivaroxaban. Finally, there's questions of resistance to aspirin. Why don't we just leave it for now? It's a very complicated subject, and we need not go into the details. So let me summarize for you. Dual antiplatelets for high-risk TIA and minor stroke. All other TIA should go on a single agent. There is no evidence that switching antithrombotic medications would make any difference. And always look for atrial fibrillation, where you would need anticoagulation therapy. I'm a few seconds over, but I'm done. I hope you found this presentation useful. And I once again congratulate the organizers for putting together this important program for my friends and colleagues in KPK. Assalamu alaikum. And if you're in a straight line, it's much better to not as good as it would
Thank you very much, Dr. Ashfaq Shoaib, for putting all the effort into your presentation. Our next speaker in the list of speakers is Dr. Ayazul Haq Azimi, who is an assistant professor in the Department of Neurology at Hayatabad Medical Complex. May I please invite Dr. Ayazul Haq to come here on the stage and present his lecture.
Respected Professor Humayun Sahab and Anticoagulation Alam Sahab, dear colleagues, our seniors, juniors, teachers, Assalamu alaikum. I had a strange feeling coming to KMC this morning. Basically, I graduated back in 2002, and I was surprised to see some familiar faces in form of helping hands. Basically, the person who is standing next to the door, he was here when I was studying in late 1990s. Probably Fozan might remember him as well. So I'm thankful to the KTH medical team, the Pakistan Society of Physicians, for arranging this nice workshop on this very important topic. Dr. Iqbal Haider, Dr. Alina, so thank you. The topic is thrombolysis, and hopefully by the end of the talk, what I want to sort of you to take away is that it's not a big deal. So why can't we do it here? And why has it not already been started over here? So what is thrombolysis? Basically, I knew quite a few of the attendees would be physiotherapists, the nursing staff, our medical students, so I've kept it very basic. And then we'll go through the patient assessment in sort of practical terms, a bit about the rating scale, checklist, and how do we care about after the thrombolysis. So thrombolysis is basically a clot busting treatment. The aspirin and clopidogrel, they are antiplatelets, not thrombolytics. So the clot busting treatment basically gives you an opportunity to work quickly and sort of open the circulation to revascularize the part of the brain which is devoid of the oxygen and the blood. IV-TPA is the approved drug, and basically in long run it's cost effective. It reduces the morbidity. The main thing is that, like it has to be given within the window. The window period meaning 4.5 hours from the time of onset of stroke symptoms. So what happens is basically a patient with fast positive, fast meaning facial asymmetry and weakness or slurring of speech. Anyone with a fast positive, they come to emergency room. You will assess the airway breathing circulation anyways, so the ABC is already out. Take a pointer, stay. So if you look at the assessment, the airway breathing and circulation Every patient has it, like when they come to A&E. Then the Glasgow Coma Scale, basically, it shouldn't take a lot of time. The RBS is important because high notes will be sort of taken as positive. And urgent blood tests when the patients are on anticoagulation, or if you're suspecting that this patient might have low platelets. Otherwise, we don't wait for the blood results. ECG. So this thing is done in the first 30-40 seconds, basically. History, when did the symptoms start and what are the symptoms? Drug history, meaning are they on any anticoagulation or any basically antiplatelets or anything? And if they have diabetes. Pre-stroke MRS, we'll go through it quickly, because if the disability is higher before this presentation with the stroke, then you try not to thrombolize them. The neurological examination, basically, you don't do it in detail. You just go to NIHSS, which we'll go through quickly. So this is MRS, which simply means that before these stroke symptoms, if the patient was absolutely fine, so it's 0, 1 is no significant disability, they were able to perform their usual duties, and so on. So basically, your main target is the population scoring 0 to 2. If you have this sort of population coming in the window period, don't lose that opportunity to thrombolize them. But if you come to this 4 and 5, they're already disabled, and basically you would expect them to be sort of aged population or have this disability because of the diabetes, hypertension. So the risk of bleeding is higher in that category. So that is the importance of knowing the MRS scoring, that what was their level of disability. NIHSS, you don't need to memorize it. Basically, when a patient with a suspected stroke comes to emergency department, you have a file for a stroke patient, and in that file, everything is there. You just need to sort of, tick box things. So there is no need, you just need to be aware of how to calculate, basically. So if you look at this level of consciousness, orientation questions, you ask them questions, and hopefully once this thrombolysis starts, we'll be trained in this NIHSS. It doesn't take more than a couple of hours to train with this NIHSS scoring. You have set questions, couple of questions, you ask them. Although Peshawar, basically, even if you ask anyone abroad about their date of birth, even if they are dying, they will give you an exact date of birth. But here, they start thinking that how old are they? So I think we have to be aware of the cultural situation. And if we do a study on this sort of date of birth thing, I'm sure more than 90% of the patients, either they don't know their date of birth or they don't give you the exact date of birth. So then response to the commands, best gaze. So every one of them has a set scoring, and you just put 0, 1, 2 in front of this thing. Then the visual fields, facial palsy, motor function of the arm, and then the leg, ataxia, sensory inattention or total sensory loss, best language capability, dysarthria, extinction. So as I told you, once you do it practically, it doesn't take more than a minute, honestly speaking. And it's in your file, you just need to put the scope. at the end of the NIHSS scoring system, you would know that, how severe the stroke is. If the score is more than 20, basically it's severe. And then 5 to 15 is moderate, less than 5 is mild, 0 is no stroke symptoms. So at the end of the NIHSS, you will have the idea about the severity of stroke. Once you do the NIHSS, the patient goes straight to the CT scan. And we should have a collaboration with the radiology department that these patients shouldn't be waiting for the scan. If a patient is already in the scanner, once that patient comes out, the next patient should be your stroke patient. And you may need to wheel the patient to the scan yourself rather than waiting for someone else to do it. So once the scan is done, if it's normal, that means that it's ischemic stroke. Then you need to go through the checklist. And again, you don't have to memorize a single bit about the checklist criteria. It's in your file. And you put the patient name, date of birth, hospital number. You have to mark, the patient has to have all these 4 or 5 variables to be eligible for the thrombolysis. So the age should be more than 16. Onset should be within 4.5 hours. There should be a measurable deficit on NIHSS, and the CT scan you have already seen. So it's very simple, isn't it? You do it every day, and there isn't any a big deal basically. If you can see the caption down there, if if the patient is more than 3 hours from the stroke onset symptoms, or if the age is more than 80 years, if the NIHSS score is high, or if you can see something on the CT scan, not bright, meaning blood, but you can see that, there is quite a bit of hypodense area, don't thrombolyze it. Because, by the time they develop these hypodense changes, the stroke has probably happened quite a bit earlier rather than within the 3 hours period. So you need to be a bit skeptical giving thrombolysis to this lot of patients. So your patient has scored yes to all these 4 variables. You go to the contraindications. And the contraindications, again, they are very straightforward contraindications. The blood pressure, you can bring it down. If it's more than 185 and systolic and 110 diastolic, you can give them labetalol or nitroprusside, depending on, the local guidelines, whichever. We got labetalol over here. So if you are about to start thrombolysis, I think the easiest thing is to sort of institute the labetalol. Then the symptoms and signs, they are not suggestive of, they shouldn't be suggestive of subarachnoid bleed. Any active bleeding, you don't give thrombolysis. And if they have had any history of intracranial bleeding, arterial puncture on non-compressible side within the last week, recent lumbar puncture within the last 7 days, suspected bacterial endocarditis or confirmed endocarditis, and aortic dissection, maybe spinal cord surgery within the last 3 months. You don't check specifically for the platelet count, but in the current situation, if a patient has high-grade fever, like and with this dyspnea and so many viral infections, if you're suspecting someone that they might have low platelet count, only then you check the platelet count. If it is less than 100, you don't thrombolyze. Similarly, if someone is on new oral anticoagulation, like the Roseban and the newer agents, and they've taken the tablet within the last 2 days, or if the INR, if they are on warfarin and if INR is more than 1.7, you don't thrombolyze. So it's very straightforward basically. You put no to all of them, so the patient is still eligible for the thrombolysis. Now, just to give a bit of flavor to you, it's not that easy in every patient. For example, if someone comes to you being pregnant, or stroke has happened in the last 3 months, major surgery or non-head trauma within the last 2 weeks, tumors, gastrointestinal hemorrhage within the last 21 days, or unruptured aneurysms, these sort of cases, you should discuss it, whether, basically that's on individual basis, and case to case whether the risk of thrombolysis are higher than any benefits. So you go through the checklist, and you will write your name, sign it, date, time, and LT place prescribed by whoever the in charge is. So the main idea is that we should do it as quickly as possible. And it's not like a patient coming in with stroke and waiting in the emergency room to be seen by someone. Any suspected stroke, ideally the ambulance crew should ring us, but practically it's impossible here in Peshawar. So I think hopefully once we start this thrombolysis, the trainees, the nursing staff, will make them aware that any fast positive patient, they have to be seen on their way to the bed. So quite a few questions you can ask whilst the patient is coming through the door. For example, when did the symptoms start? And by the time the patient is transferred to the bed or the couch, you would have almost probably done half of your job. And in next sort of 30-40 seconds, you can do the rest of it, and basically drive the patient for the CT scan and take the decision about the. So all of this door to needle time should be less than 50 minutes, and it's very possible, honestly speaking. Now, in simple words, if you want to communicate to the patient that, what are the benefits and risks. So if the patient comes to you within the first 3 hours, you can explain it to them that if we give it to 10 patients, 1 out of 10 will have significant improvement, excellent outcome. But when there is a delay, they are still in the window period, but 3 to 4.5 hours, that outcome, that number drops to 1 in 20, as you can see. And again, thrombolysis has got certain risks. The main risks are bleeding and the angioedema. So the intracranial hemorrhage is 6%, major systemic bleed is 2%, and angioedema is 5%. If you look at this, it's very important. They did quite a few studies, and you can the intracranial bleeding is very high in patients where there is deviation from the protocols. Like if you don't follow this protocol, you end up having high bleeding, 38% versus 6%. That's a significant proportion. So to reduce that risk, or to avoid this protocol deviation, you got your seniors with you. If there is a 24 hours rota, so the emergency team is there, then you got a stroke or neurology registrar with you, or even the medical SPRs who are entrusted to be on that rota. And on top of that, you got a cover from a physician who has interest in stroke or a neurologist with special interest in stroke. So, like the aim of all these things is to sort of make sure that, we are following the protocol. Post-thrombolysis care, so once the infusion starts, the IV TPA starts, basically there are 4 things: blood pressure, monitor for bleeding, signs of angioedema, and neurological examination. You do it every 15 minutes for the first 2 hours, then every 30 minutes for the 6 hours, and then every hour for next 16 hours. So it's like a 24 hours business. And then 24 hours gone, the patient hasn't had any major sort of untoward incidents. So you repeat the CT brain, and if that's okay, you can start the patient on antiplatelets. After 24 hours, you can start your physiotherapy and all those things as well. So if you look at the whole protocol, I think comparing it with the other diseases, like the meningitis or you take any disease, this is a very clear pathway. It's like a mathematical framework. You can't sort of do any wrong thing, basically. It's very easy to do it. The only thing which is sort of, obstructing, or the reason why it hasn't happened is because of initially, as Dr. Iqbal Haider Saab rightly pointed out, a few reasons, but it's not the job of one person. It's not the neurologist, it's not the stroke physician, it's not just general physician. Everyone, has to do their bit. And that starts from the patient awareness. They should be aware if someone develops stroke symptoms, they should come straight to the hospital. Like they shouldn't be waiting for it to sort of improve. Then the ambulance crew, the emergency team, the nursing staff, the clinicians, radiologists, physiotherapists, nursing staff, everyone has a key role to play. And hopefully the 2022, inshallah ta'ala, I'm seeing it as, hopefully we'll be able to start the thrombolysis. Zafar Saib, Irfan Saab, they are in LRH. Fozan is in Swat. We have started here in HMC. Dr. Iqbal Haider Saab, he has got a good team. So I can't see any reason why should we not start it, basically. The other good thing is that, usually the dose of this thrombolytic thing in European countries is 0.9 milligram per kg. But in Japan, which is an Asian country, it's 0.6. So what I think is that I will discuss with Dr. Osman Saab as well. He's with us in HMC, and I think if we are about to start it, we will start with a low dose, 0.6 milligram, for a couple of reasons. We want to go slowly, and the reason we are Asian, so and it will be cost effective as well. So it comes in 50 milligram vial, so we would just need 1 vial. So that's all from me. Time is brain, sooner is better. Even if you look at the window, it's up to 4.5, but you have seen if you do it within the first 3 hours, the outcome is much, much better compared to the last 1.5 hours. Thank you very much. Probably leave the questions for later to save the time. Thank you.
Thank you very much, Dr. Ayaz, for this elaborated discussion on thrombolysis in stroke. This is what we are aiming for in the near future, inshallah. Our next presenter has come all the way from Lahore to deliver her talk, and she will talk about neurointerventions in acute stroke. This is Dr. Saima, consultant neuroradiologist at Lahore General Hospital. She is also honorary ambassador to Pakistan in the International Union of Phlebology and the co-chair of the Mission Thrombectomy 2020 Pakistan Regional Subcommittee. So I would welcome Dr. Saima. Please come on stage and deliver her talk. Please give her a big hand to show the hospitality of
Thank you so much for this generous introduction, and it's a great honor to present here at this great symposium. So, my job is to talk about the neurointerventions in acute stroke. So, I put this title here that all fevers are not the same. So, that the etiology determines the treatment. Some of the fevers, they are viral in origin, some of them are bacterial in origin. So basically, to treat the fever, we should know the etiology. Likewise, all the strokes do not have the same etiology. Although many of the strokes, and although all strokes are presented as ischemic strokes, but underlying etiology of that ischemic stroke is different. And as far as neurointerventions are concerned, we need to know basically the underlying etiology of the stroke. So what are the variables in the stroke? So we start by location. So the stroke can happen at the branch point or it can be at the ICA. And if we see the branch, so the occlusion can be at the bifurcation, it may be at the carotid T bifurcation, it may be at ACA. And as far as internal carotid artery is concerned, the occlusion is at the bifurcation of the common carotid artery. So we divide it into two types. So basically, if occlusion is at the branch side, it may be of two types. It may be embolic or it may be ICAD. So next we talk about that, in the next slides we talk about that the embolic stroke would be due to the soft clot or it may be due to the hard clot, and we can have the intracranial atherosclerotic disease as well. As far as ICA is concerned, the commonest cause of ICA occlusion is underlying stenosis, and the second big cause is the cardioembolic in origin. So we talk about them one by one. So basically now we jump towards the mechanical thrombectomy, which is the treatment by which we retrieve the clot. So it falls into three categories. The first is the aspiration, which is adapt technique. It is basically taking the large bore aspiration catheter up to the occluded vessel and suck the clot out. The second one is the stent retriever, meaning thereby that we take a stent and we deploy it across the clot and then we drag the clot out of the vessel. And Sulumbra is the combination of both techniques. So basically we have to mix and match these three techniques in all kind of ischemic strokes as far as neurointervention is concerned. So this is a question, can we use one device in all occlusions? No. This is a stent retriever, but we cannot use the stent retriever alone, or we cannot use the aspiration catheter alone in all kind of the occlusions. We need to see what is the underlying pathology in these conditions. So there is a picture of left ICA occlusion, which is obviously cardioembolic in origin. If there is no underlying stenosis apparently seen. So first we talk about the ICA. Most commonest cause of the ICA occlusion is the underlying stenosis, and other cause is the embolic. So most of the time the embolic occlusion is due to the large LV clot, or maybe it, underlying atrial fibrillation is there also. So can we differentiate that what type of the clot is this and from where it is coming? No, technically it's not possible, we cannot differentiate. So basically when the patient comes to us, this is the picture, the patient will be present like this. I will show you further my cases also. So you can see that there is occlusion at the proximal part of the ICA. So we cannot differentiate that there is underlying stenosis or not, or it's cardiovascular occlusion or not. So what we do is this, that the blue is the long sheath, and we pull our long sheath through this occlusion and we treat it so that in both the situations it is safer to pull the long sheath all the way through the occluded vessel. So next is my case. This is about the ICA occlusion case. It's 48 years old man. He presented with a numbness in the right upper and lower lip since 2 hours. So it was a right hemiparesis and a slurred speech. He was within the IPTPA limit, so we gave the TPA patient was improved. But next day there was again the deterioration. So we did the CTA and it was a non-tandem ICA occlusion. It could be the possible dissection also. So what we did? This was the CT perfusion showing the reserve volume on the left side, and this is the selective ICA. So after the first pass, which we did with aspiration catheter, you can see the bit of it is retrieved, but still you can outline the clot, and still it is not fully not revascularized. So this is the total revascularization of the MCA and the whole ACA. After the third attempt, and we have retrieved the whole vessels, and it's a Tiki 3 score. So this was the case in which there is no underlying ICA stenosis, because in the cases of underlying ICA stenosis is there, usually the vessels re-occlude after the revascularization, and in those cases we have either have to do the angioplasty, or we have to even pass the stent. But we do it on the way back after doing the mechanical thrombectomy. So it was cardiovascular intervention. So this is another case. He was 60 years male. He presented with the left upper limb and lower limb weakness with difficulty in speech for 6 hours. So he was out of the IVTPA window. His initial NIST was 22. What we did, this is right ICA angiogram, and you can see there is a right ICA terminal occlusion. So the previous case was proximal occlusion, and this is the carotid T occlusion. So the next one is the microcatheter run. We crossed the clot with the microcatheter, and we took the run to make it sure that we have crossed the lesion and the vessel beyond the microcatheter is not occluded. So after the 3 attempts, again this is post-thrombectomy angiograms, and you can see the full revascularization of the vessels, and it's a Tiki 3 score. Now we have discharged the patient at MRS2, and after 90 days you can see this is the patient after recovery, and he is well and fine. So he was at after 90 days of this thrombectomy, he was at MRS0. So next we talk about the branch occlusions. We have finished the ICA occlusions. The branch occlusions, as I told you earlier, it may be the embolic or again the intracranial atherosclerosis disease. So what are the possibilities of the branch occlusions? The clot inside the branch, it may be embolic clot, but RBC clot, or it may be the hard kind of the clot, which is the fibrin clot. And then again there is intracranial atherosclerotic disease, which usually present with occlusion due to the organized plaque or due to the rupture of the plaque. So what is the RBC clot? Mostly the RBC clot are cardioembolic in origin, and on CT scan we have hyperdense MCA sign, which may be the blooming or the SWI. And usually these RBC type of the clots, they are usually lost at the distal M1. Distal M1 is the point of the bifurcation of M1, M2, or at the ICA top. Again, ICA top is the carotid terminus point, which is the bifurcation of ICA. So at branch bifurcations, they are usually present. This is the pictorial. By the way, I made this illustration myself. I'm very good at it. So the next is the ideal device for the retriever of the clot, which is RBC type of the clot, is the stent retriever, because these are the soft type of the clots, and they are entangled very easily with the stent retriever. And the one thing which is we we must be cautious while withdrawing the clot with the stent retriever is this, that while passing through the bend, as I have shown in the figure, one can stuck it here and one can fragment the clot. So one should be very careful. Fragmentation of the clot is very common with the stent retriever. And usually, because this is soft clot, so total retrieval takes place in the first or the second pass. This is the pictorial representation. You can see that we have the microcatheter past the RBC clot, and then there is a stent retriever over the microcatheter. It also crosses the clot. And then afterward we deploy the stent, and then we wait for 3 to 5 minutes, and then we withdraw it. So this is the stent retriever removal with aspiration. You can see that RBC clot is entangled within the mesh of the stent retriever, and we are withdrawing it along with aspiration. This is some point which is I would like to talk about this, that while doing the suction of the clot, there are so many forces which are working against the suction. For example, if there is a patent posterior communicating artery, and if there is a patent anterior communicating artery, so the blood is coming also from the contralateral side and also from the posterior circulation. So they work against the suction forces. When you are sucking the clot, the suction is ineffective because of these two elements. So what we can do to combat this? We can do the double aspiration, and I'll tell you what is the double aspiration is. So this is again the same thing. You can see there is a hanging and dangling clot at the distal end of the stent retriever, so it can fragment anytime. So as I told earlier, that we have the three types of the categories by which we can do the mechanical thrombectomy. I have talked about the stent retrievers. Now the aspiration. Aspiration is also called a direct aspiration first pass technique. And this is the pictorial representation. You can see the microcatheter. You take the microcatheter up to the clot, but you do not cross the clot. As in the stent retriever, you cross the clot with the microcatheter, also with the stent. And the suction catheter is in the green color suction catheter. You can see it down. Next, over the microcatheter, you bring the aspiration catheter up to the clot, and then you remove the microcatheter and you do the suction. So basically, these two techniques are a bit different in the stent and the aspiration both. So what is the material for the DAP technique? These are few of the hardware material which are very commonly used, and they are also being used all over the world. So basically we have to use the 8 French femoral sheath with the long sheath of Neuron Max, and we typically use the Sophia plus 6 French aspiration catheter. There are a number of other aspiration catheters all over the world. With the 27 microcatheter, the main tip is this, that we have to use the J-shaped wire, because if you do not use the J-shaped wire, the wire can enter into any of the perforator and it can go anywhere and you can have the rupture vessel. So this is the figure, this is from my own setup, and you can see the blue one is the long sheath, the next is the aspiration catheter, and the next is the microcatheter with the micro wire. And you can see that all of these I have 3 separate attachments which are attached with the heparin saline. So you need to irrigate with the heparin saline all of these setups all the time, and then you do the suction through double suction with the 50 cc syringes by connecting them with these. This is that how you place the Neuron Max. I think this is a bit technical, so I will pass this. So previously I talked about the double aspiration. Double aspiration is using the stent retriever and the aspiration catheter both. So you deploy the stent across the clot, as you can see, and then you bring the suction catheter up to the clot, but not up to the, you do not cross the clot, and then you bring down the whole assembly. You do the aspiration both from the stent retriever and from the aspiration catheter at the same time. And this is the most effective way to do the mechanical thrombectomy. Next is the case who is 37 years male, and he is presented with acute onset of the right upper limb and the lower limb weakness with absence in speech. That is the global aphasia, and his power was 0/5, and he already has endocarditis and he was MR positive. So this was initial CT, and you can see the hypertense M1 sign in this on the left side with the insular ribbon sign. As I told you earlier, the hypertense M1 sign is usually seen in the RBC type of the clot. So this is at least some degree of the information you can get from the CT. So it's a left proximal M1 occlusion, and post thrombectomy TK2B we have achieved by using the Solumbra technique. Solumbra technique is using the stent retriever with the aspiration catheter both. And you can see that this is the CT scan after the 24 hours, in which we have the stent. We left the stent there, and then there is a subtle infarct, which is the infarct which already happened. That was the core. So we have saved the penumbra, and you can see that patient is well and moving all 4 limbs. There is another patient who presented with the subarachnoid hemorrhage, and it was A2A3 aneurysm. While we were doing the procedure, that was the coiling. Due to the manipulation of the catheters, some of the thrombus go up, and we have this ICA occlusion. In the first picture, you can see that there is a distal A2A3 segment aneurysm, and in the next, you can see there is a occlusion of the left ICA top. It happened due to the manipulation of the catheters, what we were doing. So there was no other way out that we have to do the mechanical thrombectomy right at the same time. So we retrieved the clot, and this is microcatheter run, and this is the total TK3 recanalization after the first attempt. And after we retrieving the clot, we again did the coiling of that aneurysm too, and he was discharged uneventful. So our third category is the occlusion in the ICAT. So these patients who have the underlying stenosis, and then they present with occlusion also, that is with ischemic stroke. They have the different kind of the picture. They may have the history of TIAs, they have calcium in the vessels, there is no hypertense MCA sign, so they have the better collaterals. As you all know that due to the underlying ICAT, collaterals are already developed. So in these cases, the clot is like this. There is underlying atherosclerosis, and then there is a clot, which is secondary, causes the secondary occlusion. So in these cases, the one of the tip is this, that you never, when you try to retrieve the clot, the stent was never fully opened. So this is indirect sign. And after some time, the one thing is this, that when you remove the clot, temporarily the vessel is opened, but after some time it is re-occluded. So the strategy is different in treating the ICAT lesions. In these lesions, you don't have to put the stent again and again, and you don't have to aspirate again and again. The other strategy is this, that you give the bolus dose of the glycoprotein 2B3 inhibitors or anything like that, and then you wait. And if there is further occlusion, then you can do the angioplasty, and you do not use the coronary balloon for this. There are dedicated neuro balloons for this purpose. Even after the angioplasty, you have to wait for some time, and even if there is more occlusion, then you can have to leave the stent there. And but this is the last resort. We want to avoid this. We should avoid this, because if you leave the stent there, then you have to put the patient on the dual antiplatelets, and then it would be a great problem again. So it's the last resort. So coming towards the basilar stroke, the strategy for the basilar stroke is this, that the orientation of the vessels is like this, that the aspiration technique is better as compared to the stent retriever. So our first line is this, that we always try with the aspiration first. So there was a patient who was 53 years male. He presents with a giddiness, vomiting, followed by outer sensorium and left-sided weakness. 12 hours back, and his initial GCS was 4. Because my topic was different, so I didn't talk about the hours. For arterial circulation stroke, the ideal is the 6-hour time window, but you can go up to 16 hours. As compared to the arterial circulation, if the patient has the posterior circulation stroke, there is nothing to lose. Even within 24 hours, you can try, even if there is no brainstem infarct. Massive brainstem infarct, I must say. So MRI has a great, specification as in the basilar strokes. So it was a typical basilar occlusion. You can see the CT. It was typical basilar occlusion. We did the aspiration, and we retrieved the clot, but unfortunately this patient died. So we talked about the RBC clots, we talked about the ICAD, now we talk about the fibrin-rich clot. These are the hardest clot to aspirate. And we need to look into this, that how we treat these kind of the clots. They usually lodge at the distal MCA. There is some kind of the nidus which is present behind. There is absence of the hypertense MCA sign. Underlying vessels are normal, collaterals are minimal. So if the underlying vessels are normal and the collaterals are minimal, meaning thereby that associated ICAD is not there. So I have one case of fibrin clot as well. He was a 40 years male, presented with the right upper and lower limb weakness with a power 0/5. He was known hypertensive smoker. Hypercholesterolemia was there, and he presented to us with a wake-up stroke, and his initial NISH was 25. The aspect was 5, and as you know that the guidelines are this, that we should not treat the patient if the aspect is less than 6. And you can see that there is a subtle early fast in the left MCA territory, but the patient was very young. So we tried mechanical thrombectomy on this patient, thinking that he might get benefited. So you can see that on the DSA there is a left proximal M1 occlusion. So this was the worst case to try. We did the 4 attempts. In the first attempt was with the aspiration catheter, and then the 3 attempts with the Solumbra technique, that is with the aspiration catheter and stent retriever both. And you can see that every time when we obtained the total revascularization, after 2 or 3 minutes the vessel moved again. Then we tried again, then vessel moved again. And after the 4th try, you can see that minimal dissection, it ends up into the dissection. And you can see that we cannot retrieve something, there is a very minimal clot. So we left there, sometimes nothing works, and this is the CT after 24 hours. But still I think he would end up with the MRS3, but we discharged him at MRS2. So this is one of the cases in which the clot was very hard, and it was a fibrin clot because there is no associated ICAD there. So what we should do? Suction is a better choice in the fibrin clot. We should not do the stent retriever suction with the aspiration catheter is a good choice. So my last case is a 15-year girl. She presented with the right-sided upper and lower limb weakness with a loss of speech for 5 hours. It was right hemiplegia with a 0.5 power in both upper and lower limbs and with a global aphasia. She is the patient of restrictive cardiomyopathy, and she was on warfarin, and NISH was 17. So this was the echocardiogram and initial ECG. This was the CT with the SPECT 10. You can see that there is no sign symptom there. So there is proximal left ICA occlusion. Now, keeping the history in view, you can easily detect that it is cardiac in origin. And the next is the microcatheter run, which is taken through the microcatheter after crossing the clot. So we have used the Solumbra technique in this case. You can see the proximal markers of the stent, and behind is the aspiration catheter. So we retrieve the clot by using this technique. And you can see that post-thrombectomy TICI 3 score and the clots are also there. So the patient would discharge with the upper limb grade 2 and lower limb grade 3 power, and these are the sequential CT. Sometimes due to the contrast extravasation, we can have the false image that there might be a hemorrhage. So in these kind of the cases, you shouldn't take it as a hemorrhage. Rather, we can repeat another CT scan. If there is a contrast extravasation, it will go, and if it is a hemorrhage, it stays. So we ideally put the patient on the antiplatelets after getting the CT scan done after 24 hours. So this was the patient with the power 5/5, normal speech, no cognitive decline at 90 days. So these are the videos.
पढ़ती हो आप? कौन सी क्लास में? 9th में? और स्कूल जाना शुरू कर दिए? अभी नहीं किया?
This was at 90 days after the discharge. So I end up my talk here that all that glitters is not gold. I hope this discussion would be fruitful and you give some of the idea about the mechanical thrombectomy and the intervention we are doing at our own setup. Thank you.
Thank you very much, madam. It was a very nice and elaborated presentation and was also full of examples from real life. Our next presenter is Dr. Muhammad Fawzan Khan, who is the graduate of Medical College Peshawar. He is MRC Medicine, has also completed his core training from from Edinburgh, and a consultant physician in internal medicine and stroke medicine. He is also the vice president of the Pakistan Stroke Society, and he will be shedding light on anticoagulation in atrial fibrillation and stroke. So Dr. Muhammad Fawzan Khan, please.
Assalamu alaikum, ladies and gentlemen, and my great teachers, Professor Khyber Saab, who is not a great physician but also has got a good grasp of social aspects of the life. Professor Humayun Saab, his clinical acumen was always popular among students. Dr. Saab, and I've never seen anyone doing a sleek examination of cardiovascular system better than him. And Dr. Jamal, who was a TMO, but he used to teach us a lot of clinical methods. So my name is Muhammad Fawzan Khan. I'm a 2002 graduate of Khyber Medical College, and I spent almost 14 years in the UK, worked here as a consultant. I was member of the faculty of School of Medicine at University of Sheffield. Then I came here, we established the first stroke unit in KPK at RMI. Unfortunately, it was very difficult to get LT place in those days. We worked hard for that. It's been approved by the DREP, and inshallah, KPK very soon. Thrombolytic treatment will start. Hopefully, come back to me soon. So the talk which has been assigned to me is about the use of direct acting oral anticoagulants in the context of ischemic stroke. So the terms DOX and NOX are interchangeable, but there was a paper which suggested that these agents are no more novel. So N is for novel or non-vitamin K antagonists. But as these medications have been in the market for almost a decade, so the better term is DOX, which means directly acting oral anticoagulants, which basically explains the mechanism of the medication used for anticoagulation. So I'm going to talk about DOX, the evidence, basic pharma, how to start DOX, some special clinical scenarios, the monitoring and reversal, the bleeding complications and how to manage, and the follow-up of these patients. So this is the website of Pakistan Stroke Society. It is a very useful website, and inshallah very soon very important stroke guidelines will be uploaded. So I start with a clinical scenario. We learn from real life scenarios. So a 45-year-old male patient, 3 days history of right-sided weakness, unable to speak, no significant past medical history of note, non-smoker. So do you think this is the right approach? I don't think so, because we don't want to see patients coming 3 days after onset of stroke. The whole aim of this symposium is that these patients should come to the emergency department as soon as possible, and ideally within 4.5 hours. But it's very routine to see these patients in our clinics, in outpatient departments, in emergency department, turning up to hospital 3 days after the onset of stroke, after attending a lot of Peer Sahiban. So whenever you see a patient, the principles of emergency management, be it a medical emergency or a surgical emergency or a pediatric emergency, whatever it is ABCD approach. So A is for airway, make sure the airway is clear. If not, consider oropharyngeal airway, consider tracheostomy, consider intubation. Then next step is breathing, so you assess whether patient is self-ventilating or needs non-invasive or invasive ventilation, auscultate the chest, check the respiratory rate, check the oxygen saturations, and then come to the C component, check the heart rate, check the blood pressure, check the capillary refill time, auscultate the heart. And then this patient had a neurological assessment and it showed NIHSS of 22, which means very, very severe stroke. So patient had global aphasia, right side visual inattention, gaze deviation to the left, right upper motor neuron facial weakness, zero power, upgoing plantar, so severe stroke. This is the CT. We don't want to see these CTs coming to us. We want patients to present early. But as you can see, it is a multi-territory extensive infarct involving both the anterior circulation and the posterior circulation. So bad news. This is the ECG. So for medical students, this is the ECG of atrial fibrillation. So acute ischemic stroke is a major cause of mortality and morbidity worldwide, as Dr. Iqbal mentioned. But in the context of atrial fibrillation, it is associated with more severe ischemic strokes and longer TIAs. And evidence suggests that AF is associated with high recurrence rate of strokes. So patients with AF who suffer an ischemic stroke appear to have a worse outcome as compared to patients who have sinus rhythm. This is very important sign. If I can convey this message today, then I think I fulfilled my job. Time is brain. So just look at this. If somebody is having stroke, then the patient is experiencing a typical large vessel occlusion, 120 million neurons, 830 billion synapses, 714 kilometers of myelinated fibers are lost each hour, and 1.9 million neurons, 14 billion synapses, 7.5 miles of myelinated fibers are destroyed. Compared with the normal rate of neuron loss in the brain aging, the ischemic brain ages 3.6 years each hour without treatment. So reperfusion and preventing stroke is so important. This was actually published in Stroke Journal and the topic was time is brain. So now coming to the history, all of us are familiar with warfarin. Warfarin is basically a rat poison, but the rats have modified their genes, so it is not working on rats anymore. Historically, the warfarin has been the standard of care. It is very commonly used, but it is not limited therapeutic range of IR. It needs monitoring. Unfortunately, we don't have very good facilities of measuring the IR accurately. It is affected by diet, by genes, by drug interactions. We have got good antidotes for warfarin, which is vitamin K and prothrombin concentrate complex. Okay, so as comparing warfarin to the DUEX have got some benefits. They've got predictable effect and they do not routinely require monitoring. They've got fewer food and drug interactions. They've got a fixed dosage. For warfarin, you have to dose the warfarin according to the INR. And unfortunately, the skills of many clinicians are not very good to properly prescribe the warfarin. The DUEX have got a shorter plasma half-life, and the efficacy and safety ratio is better. Now, there are different types of DUEX. In Pakistan currently, we have apixaban and rivaroxaban. Dabigatran is not available in Pakistan. So if you look at XA, so rivaroxaban, XA, apixaban, XA. So the target is factor 10A, and the dabigatran works on as antithrombin. So the benefit of rivaroxaban, apixaban, and dabigatran is that it starts working very, very quickly within a couple of hours. We do not require any routine monitoring. Rivaroxaban is given once daily, and the rest of the two medications are given twice daily. And these are the common drug interactions. Now I will talk about dabigatran. The evidence for dabigatran comes from RELIGHT trial, which was published in 2009 in North England Journal of Medicine. So it was a very huge trial. It enrolled almost 18,000 patients with non-valvular AF. And they had at least one of the risk factors which are mentioned here. The 951 centers were involved in this trial in 44 countries. Dabigatran was given in a blinded fashion and warfarin was administered unblinded. So the researchers were looking at the primary outcome, whether patients receiving dabigatran will have stroke or systemic embolism. So if you compare it, then the incidence was 1.53% per year in patients receiving 110 milligram of dabigatran, and it was less in patients who were receiving the standard dose of 150 mg. Okay, so the performance in preventing stroke in the context of AF, dabigatran was better. And both the doses of dabigatran were non-inferior to warfarin. If you look at the risk of hemorrhagic stroke with warfarin, then in summary, all the duets have got less risk of intracranial bleed as compared to warfarin. So we can see here in nutshell, dabigatran is at least as good as warfarin, actually better at 150 mg dose. The risk of intracranial bleeding is less with dabigatran, so this is one benefit. However, the warfarin was safer as compared to dabigatran when we talk about the risk of GI bleed. Okay, now coming to apixaban. Apixaban is now available in Pakistan, and it is one of my favorite drugs. Apixaban, the trial was Aristotle trial. It was published in North England Journal of Medicine in 2011. It was again a multi-center, double-blind comparative trial. Again, almost 18,000 patients were enrolled, almost same number for warfarin and apixaban. And the primary outcome was again to look for stroke or systemic embolism, and you can see that apixaban performed better than warfarin. Now look at the risk rate of hemorrhagic intracranial bleed. So it was much lesser in apixaban group. And again, if you look at the major bleeding risk, apixaban was performing better. This Averroes trial, which is again based on apixaban, is very interesting because we have a lot of patients, elderly flare patients, in which we think if we give them anticoagulation, then there will be high risk of bleeding. However, in Averroes trial, it was observed that in patients with AF, thought to be unsuitable candidate for anticoagulation with warfarin, apixaban significantly reduced the risk of stroke and systemic embolism without increasing the risk of major bleeding or intracranial hemorrhage, even when compared to aspirin. So the safety profile was, as good as aspirin in terms of risk of bleed. Now, rivaroxaban. So rivaroxaban has been in Pakistan for quite a few years. The trial was Rocket AF. Again, it compared with vitamin K antagonist, i.e. warfarin, published in North England Journal of Medicine. Again, big number of patients. And again, the result was that rivaroxaban was better than warfarin in preventing stroke or systemic embolism. The major bleed risk was similar when we talk about major bleeds. However, again, rivaroxaban was associated with higher risk of major GI bleed when we compared it with the rivaroxaban. So when I said apixaban is my favorite drug, it is better than warfarin in preventing stroke, and the risk of intracranial bleed or GI bleed or any other major bleed is much less with apixaban. Okay, so I give you another scenario. A 75-year-old male patient who came with right partial interior circulation stroke. So when we say TACs, PACs, LACs, these are called Oxfordshire classification of stroke, also called Bamford classification. Bamford is a neurologist who is still working in Leeds. So basically, TACs means total interior circulation stroke, which is very severe. Then PACs, then we have got LACs, and we have got POCs. POCs is posterior circulation. So this patient presented with the right PACs. The homework for today is to read about Chads-Vax 2 score and Hasbred scores. Chads-Vax 2 score tells us about the risk of having stroke if somebody has got multiple risk factors, and the Hasbred tells us about if you start them on anticoagulation, then what will be the risk of bleeding. So this patient had pansystolic murmur in the mitral area. ECG showed sustained AF, which was a new finding, and the transthoracic echo showed moderate MR, mild aortic stenosis. So the question is, as we know that DUEX are licensed in non-valvular atrial fibrillation, will you give this patient warfarin or a duet? This is my question. So if anyone from audience wants to participate or give me the answer. Duet or warfarin? So those for duets, if they can raise the hands. Those for warfarin, if they can raise the hands. Okay. But the patient has got a valvular heart disease. So this comes to what is valvular heart disease in the context of atrial fibrillation. So it's a matter of debate. So the currently widely accepted definition includes only the patients who have mitral stenosis, which is usually a sequelae of rheumatic heart disease, or if they have got a metallic heart valve. Only those patients will be considered to have valvular heart disease in the context of anticoagulation with 2X. So the pneumonia case, mechanical and rheumatic mitral valvular AF. So this patient is a candidate for a DUEC, which the majority of the audience identified correctly. So how to start DUEC? So again, it is a discussion with the patient or their attendants, because here people do not let patients talk. If a DUEC is considered, then establish why you give them DUEC, and documentation is vital. Now, the practical points, dabigatran is not compatible with enteric route, which is NG tube and PEG tube. However, apixaban and rivaroxaban can be given orally and through enteric route. In stroke prevention, all of these agents are superior to the warfarin. If you come to the major bleeding, then they are at least not having increased risk as compared to warfarin, except for GI bleed, in which dabigatran and rivaroxaban carry the higher risk, but apixaban is safer, or at least not higher incidence of warfarin in the terms of major GI bleed. So in a nutshell, they are better than warfarin in preventing stroke. The risk of intracranial bleed is less with the use of all these three medications. The risk of major GI bleed is higher with dabigatran and rivaroxaban, but similar with apixaban. Okay, now we compare warfarin with DUEX. So warfarin has been in practice for more than 90 years, and DUEX came in 2011-12 time, so almost a decade. Warfarin is cheaper, DUEX are expensive. Warfarin needs to be in therapeutic range for at least 65% of the time. But with DUEX, we know that when we start it starts working within few hours. INR gives a good indication of compliance, but we know are not reliable, and some clinicians are not competent to prescribe the warfarin dose as per INR correctly. DUEX do not require routine monitoring. The warfarin is good and well-known antidotes, and the antidotes for DUEX have come to the market, but unfortunately have not reached Pakistan. So as I said, DUEX start working quickly. Warfarin takes time for the INR to be therapeutic. Okay, so warfarin has got a lot of interactions with drugs and food. DUEX have got fewer. Warfarin as such can be given even in patients with advanced renal disease, but there is a risk of vascular calcification. DUEX, you have to consider their creatinine clearance in order to give them the correct dose. So I will skip all this. We compared. There are some guidelines from 2016 by Royal College of Physicians, very, very concise. It covers from acute stroke management, blood pressure management, anticoagulation, and the rehabilitation. So all the aspects, it's freely available on the Royal College of Physicians website. Okay, if you want to switch someone from warfarin to DUEX, how do we do it? So if scenario, a 70-year-old female patient admitted with multi-territory ischemic strokes. She was on warfarin for AF. Warfarin has been restarted 1 week ago with the latest INR of 2. When you see her INR results from the past, you see that most of the time INR has been subtherapeutic. So if you give warfarin and the INR remains subtherapeutic, then basically we are giving them candies. It's not working. So you discuss with the patient and she agrees that she is happy to go with apixaban instead of warfarin. So when will you start the DUEC now? Because already INR is 2. So the answer is, for dabigatran, you discontinue warfarin and start dabigatran when INR is less than 2. With apixaban, discontinue warfarin, and again you can start when INR is less than 2. And with rivaroxaban, you can stop warfarin and start rivaroxaban when INR is 3 or below. Is there any benefit of switching from one DUEC to another? The simple answer is not much evidence that, sorry, not showing. Okay, so not much good evidence if you want to switch, for example, from rivaroxaban to apixaban, etc. But of course, if there's a patient at increased risk of GI bleed, then apixaban will be preferred as compared to rivaroxaban. So dabigatran is anyway not available in Pakistan so far. Now we discuss about giving thrombolytic agents. So basically, if patient has received DUEC within last 48 hours, in our circumstances, they are not candidate for thrombolytic agent. However, in countries where the antidotes are available, then they may be considered. So coming to the monitoring, a lot of tests have been suggested. Unfortunately, they are not practical for us because these are sophisticated tests which are not readily available in our setup. Basically, DUECs do not require routine monitoring. But if you want to talk about specialized tests, then diluted thrombin time and E-carrin clotting time, etc. are available. The important thing to note is that for DUECs, INR levels are not reliable. So they are not monitored on the basis of INR levels. For factor 10A inhibitor, the PG gives some quantitative information. However, anti-factor 10A chromogenic assays have been developed and they are more reliable to look for the activity of rivaroxaban and apixaban. Now coming to the antidotes, the first antidote which was approved by FDA was in 2015. It is called Praxpine. It is available in other countries and it comes in a ready-to-use intravenous dose of 5 grams, which is the 2.5 grams, 2 vials. It has got no prothrombotic effect and it gives very immediate and complete and sustained reversal of the dabigatran. Now this is the antidote which works for both rivaroxaban and apixaban. It has been approved by FDA and it is the first antidote indicated for patients treated with rivaroxaban or apixaban when reversal of anticoagulation is needed due to life-threatening or uncontrollable bleeding. So I really hope these will be available in Pakistan, inshallah, very soon. Now, another practical scenario, a patient is having surgery and they may be on apixaban or rivaroxaban. So what to do? If it's a low bleeding risk procedure, stop it 24 hours before the procedure. And even for high bleeding risk, rivaroxaban can be stopped 24 hours prior to the procedure. If for apixaban, it should be stopped 24 hours before the low bleeding risk and 48 hours before the high bleeding risk surgical procedures. So these are all practical things which all physicians are asked. The surgeon will send us a call. Patient is on apixaban. I'm doing a pancreas surgery. When to stop it? So the answer lies here. So management of bleeding, because they are anticoagulants and patients can have bleeding and patients do have bleeding in specific scenarios. So again, the principles of ABCD, immediately stop the DUEC. If we have got clinical hematology available, discuss with them and document the time and of the last dose of the DUEC and consider activated charcoal if it was given within 2 hours. Ensure IV fluids because diuresis will help the renal clearance. Send blood samples for all these bloods. Consider platelet infusion if thrombocytopenia or antiplatelets. If the antidote is available, then administer the antidote.